The first time it happened, I went to the school book fair, and somebody's like, I smell skunk, I smell skunk. And later, I went and I grabbed my coat, and I'm like, oh, that's my weed. I'm the skunk. The message I tell my kids about marijuana is that it's not that much different than the other medications that are in the pill bottle. So just as they would never touch my pill bottles, they would never touch marijuana. I'm Jessie, I'm a mom, and I smoke weed.
Thanks, Jessie. You're listening to Zana Medical's Health Lab. I'm Seth Lorenzi.
And I'm Jeremy Cosson, Clinical Research Liaison for Zana Medical and an investigative health and science writer for Leafly.
So, Health Lab is a podcast in episodic series format. Each series focuses on a specific medical condition, in this case insomnia, through the lens of clinical cannabis, and each episode breaks the subject down further through different populations. This is episode 2, and we're talking about women and insomnia. Insomnia is incredibly prevalent in this country, and it's a special problem for women. I wanted to just start framing the issue by hearing a little bit of audio from Dr. Kim Babson. She's the researcher and sleep expert we met back in episode 1.
Yeah, so insomnia at this point is reaching epidemic proportions. I think about 40% of the U.S. population will experience some level of clinical insomnia at some point in their life. There's definitely folks that are at higher risk to develop insomnia. So women are about 1.5 times more likely to have insomnia than men.
Exactly. Women are known to have much higher rates, as Dr. Babson says. Jeremy, in a nutshell, why is that?
Well, actually, in a nutshell, it hasn't been totally clear, to be quite honest with you, but they have done some research on it. Pretty recent study. They looked at how the sleep-wake cycle differs between men and women under normal conditions with healthy individuals, and it revealed quite a bit. So actually, what they did is they conducted this study, I think, in Canada, McGill University. So they had 15 men, 11 women, and they had to spend 36 hours in a lab, which sounds a little bit crazy.
Yeah, thank you for taking the words out of my mouth.
Yeah, I'm sure.
This is one of those famous sleep lab studies.
This is
right?
one of those famous sleep labs, and it gets worse. It's not just a fun sleepover for 36 hours. What they did is they took a catnap paradigm. So basically they would turn the lights on and off, like they'd let them sleep for an hour, and then they wake them for an hour, and then analyze a bunch of different metrics.
Isn't that technically torture? Not to go dark, but
it does sound not like the most fun study that I'd actually want to be in, and hopefully they were well compensated for it. But,
yeah, nice.
But what they did is they actually, you hear about melatonin quite a bit, so they actually measured melatonin levels. So melatonin's actually our central sleep hormone. So they looked at both wakefulness and sleepiness and measured women during different phases of their reproductive cycles as well.
So that's why some people take melatonin to go to sleep.
That's why
they're adding their own hormones.
Yeah, they're supplementing those hormones.
Yeah, interesting.
So what actually they found is that women's sleep cycles ran at an earlier phase than men's. So
what does that mean?
What does that mean?
Experientially,
what that means is that they became sleepy a lot earlier, and their nighttime alertness was lower than men's. So basically, women start sleep at a later time than men relative to how their bodies are set. This is why women may have more difficulty falling asleep and staying asleep.
Yeah. I asked for a nutshell. That's pretty nutty.
Yeah.
I mean, not crazy. I mean, pithy.
Pithy.
Yeah.
Exactly.
Yeah, that's to the point.
Okay, so in a nutshell, there's quite a few aspects that influence women differently than men. So hormonal changes during the menstrual cycle, also during menopause, that can influence sleep. Hot flashes, night sweats, during pregnancy, hormonal, physical, emotional.
I'm thinking of something Rhonda said. She was woken up by a power surge.
By her baby? Or
No. It's akin to a hot flash. It's called a power surge.
And there's also certain medical conditions that women are also a little bit more inclined to. So different things like anxiety or fibromyalgia, some different sleep disorders, and restless leg syndrome. For some reason, they're at higher risk for those. And those cause insomnia too. And of course, one thing we can't forget is that women are often the CEO of the household and working a job outside the home.
Right. I think it's safe to say that women are expected to perform or show up in the household in a way that men may not be.
Exactly.
Yeah. All right. In previous episode, we covered sort of top-level questions. Like, what is insomnia? Can cannabis treat insomnia? Is cannabis safe? Can I take it around my family? I want to add something to that, which is potentially an issue for anyone, but I think especially women, as they tend to make the decisions about healthcare in their families. And that is, can I talk to my physician about cannabis? Given its historical and legal background, this is tough for a lot of people. You and I have talked about a potential opening in that conversation, and that's bringing up the endocannabinoid system.
Exactly, Seth. So, as you know, the body has our own cannabinoid system called the endocannabinoid system, which is a homeostasis system essentially, but it's influential in every aspect of our physical and emotional health.
But what does that have to do with doctors not understanding cannabis?
So we only discovered it maybe 20 years ago, 25 years ago, and medical school still hasn't really caught up to the fact that we have this important physiological system, which is perhaps arguably the most important physiological system in our body.
So wait a second. So medical schools aren't talking about the body's own regulatory system, or at least this giant aspect of it?
Correct. Most medical schools do not cover the endocannabinoid system, or they cover it very superficially, but most do not.
Wow. That's a little brain bending.
Yeah, and I've spoken to deans at medical schools and talked to even some people at Harvard Medical School, and I asked, why don't you teach the endocannabinoid system? And they just said, that's a good question. That's a really good question. I don't know. So it wasn't like some vast conspiracy or anything like that, but they don't teach it.
We're in agreement. That is a good question. So in other words, for a lot of physicians, cannabis is an invalid medicine.
Most of their education is kind of limited to sort of the harmful effects of, or looking at cannabis as a recreational drug and looking at it from an addiction or a misuse perspective, not as a medicine.
Not as a medicine. Yeah. That makes a lot of sense, Jeremy.
And it's not just unique to cannabis, it's plant medicine, right? They don't really learn about plant medicine.
I totally agree with that, as a matter of fact. I live in a community in which naturopathy, what most people would call alternative medicine,
Well, you live in Portlandia.
Thank you. I'm not going to touch
I've seen the
one.
show.
Well, it's ironic. The bookstore featured in the show is we walked by it last night. It's
really?
about a block from this house. So yeah, we're deep in that. But my point being that what most people would call alternative medicine, acupuncture, massage, alternative therapies, are well established and part of the system here. They're taken for granted as being valid forms of therapies. Elsewhere, that's not really the case. But as acceptance of clinical cannabis spreads across the country, as it clearly seems to be doing, I wonder if those quote-unquote alternative therapies are going to kind of follow suit and gain that wider acceptance.
It'll be interesting to see, definitely.
All right. So another high-level question that people have about cannabis, no pun intended, is we address the question of whether it's safe as medicine, but especially when we're talking about insomnia and functioning around one's family, what about a hangover effect? What about the day after if you're using it to treat insomnia? How much of a concern is that really?
Well, I think the concern with how it would make you feel, the next day is pretty similar to any sort of sleep medication. And so all sleep medications tend to affect people obviously differently.
Mm-hmm.
And some of them have a very pronounced effect on especially early rising or when somebody wakes up, they have that, what you mentioned as a hangover effect.
I have to interject. We talked about melatonin earlier. One reason I don't take melatonin is because it gives me a hangover effect.
Yeah,
even though it's
me too.
Yeah, well, there you go.
Yeah.
I mean, even though it's, again, going back to alternative medicines, it's theoretically a fairly gentle approach. I mean, compared to, some of the pharmaceuticals. And yet I can't take it. It has too big of an effect on me.
No, that's absolutely true. So you can't really just generalize and say that cannabis won't have any sort of morning effect on or hangover effect on anybody, or it will always, because it is highly individualized. And, it also depends on sort of, dosing and everything like that. So
in other words, I mean, it's like any other medicine
exactly.
that
I'd
you
say
take.
I haven't seen any sort of notable differences that it's more pronounced or less pronounced necessarily.
Yeah.
It's definitely less pronounced though than, say, alcohol or something like that, which is not really an accepted form of medication for sleep anyway.
Yeah, I've actually invented my own sleep medication. It's called Bourbon PM.
Bourbon PM. I think I'll avoid that one.
Yeah, it might be a good idea.
Yeah.
Okay.
Oh, but is that like? Oh, you have the Bourbon AM too, right?
Oh, there's a concept. Yeah. Moving on.
Moving right along.
Right. So, as always, my question is going to be, what's the process? Where do we go from here? We've introduced some higher level concepts, some sort of mid-level concepts, but what do we do with it all? How do we synthesize it and form a plan of action?
Well, Seth, we're going to learn a lot more in this episode, but definitely want to hammer home the point that these are big, complicated issues. And so it all comes down, what's my favorite word?
Cannabis. No, insomnia. Process.
Process, exactly. Or data was my first, but process. Yeah. Process and data. They're very close, first and second. Okay. But process is so important. And that's really where Zana Medical comes in, is helping you with process and guidance.
I think a lot of people want an answer.
Easy answers.
An easy answer
to complex problems.
And an easy treatment. A pill. Pills are appealing that way. You take the pill and something happens. And in my experience, real change is affected more incrementally. What's the watchword? Go low, go slow.
Start low and go slow.
Yeah.
But no, and you made a great point, and that's that.
I did.
In society, no, we too often want just a magic pill. And I mentioned this before. There's no magic pill. There's no magic, or in this case, magic flower.
Right.
There's many factors here that we also are going to be looking at and that are important. Sleep hygiene is extremely important. That's the first step. You mentioned like cognitive behavioral therapy or meditation, mindfulness exercises, relaxation exercises. All these things are really important. And so we shouldn't actually ever look just to a magic pill or a magic flower or anything like that to solve all of our problems. It really does take the totality of what was your term, the totality of the
phrase I used was the totality of you.
The totality of you.
You are a complex system and you're interfacing with these other complex systems, cannabis and insomnia.
Exactly.
Yeah. Wow. I said something memorable.
I almost remembered it.
Oh, yeah, right. Okay, cool. Thanks, Jeremy.
Thank you, Seth.
Okay, welcome to segment 2. I want to talk about some issues that are specific to women, and I want to start bringing in some patient voices because they're going to be able to talk about their experiences much better than you or I will. Let's start with one big issue that impacts insomnia, and that's childbirth and parenting. We're going to hear from Paige. She's a mom, and she's a psychotherapist, and she struggled with insomnia for nearly 15 years at this point. She talked with Jeremy earlier this year.
It has definitely increased in its intensity. And I had a baby about 2 years ago, and so that really, things got really crazy because I was with him every night, and he was waking up every 2 hours. He didn't sleep through the night for 18 months. So that also kind of triggered my insomnia.
Was that as therapeutic for you as it was for me?
I hope it was therapeutic for her.
Yeah, I hope it was therapeutic. I mean, that's a recurring theme that we hear among many moms is that, is with a new child, a baby, and that can really exacerbate insomnia symptoms.
Yeah, well, Jeremy and I are both fathers as well, and it's safe to say that my wife certainly did the brunt of the early child rearing, especially as she was nursing. Okay, let's hear a little bit more.
Yeah, it was really hard. Actually, the first maybe 2 months, well, it's funny because when he was born, I didn't sleep for 72 hours. I remember really distinctly because I was in labor for 28 hours. I didn't sleep. And then I couldn't fall asleep after he was born for 2 days. So I had delivered a child naturally, without medication. It was like so exhausted. So that was kind of the start to it.
I love that she's laughing. I mean,
yeah, I don't think I would be laughing at that point.
No, not so much. And I'm also flashing back to the night that my daughter was born. The midwives left, our friends and family left, and my wife and I were left with this kid. And really, that was the first time I felt, oh my, wait, we have to take care of her. We have to do something now. Everything up to then had been preparation, and then suddenly the room clears out and you're left with a newborn. And that's when it really begins. Anyway, let's get back to Paige.
So it was pretty awful, especially for about 18 months. I was really irritable and, I was just my mind wasn't functioning well. My memory was bad. It was really hard. I'm really glad it's over.
Again, she's laughing. It's kind of amazing.
Well, I bet actually that story resonates with a lot of moms.
Oh, it has to. I think Paige's experience was unusual. She delivered without meds. I'm not sure if she delivered at home or not, but the impact is the same. I mean, it's enormous changes happening in a very short time to your body, and in many cases, insomnia is one of those. Again, not the root cause, but it's one of the symptoms of other issues.
Right, and oftentimes childbirth is one of those things that can actually trigger insomnia or bring it on.
Yeah, or
exacerbate it.
Okay, next. Let's talk about anxiety. We're going to hear from Jessie, who started this episode off. She's the woman featured in that Viceland spot. She's a mom and a nurse.
You really like the Viceland spot.
Am I saying it in this kind of spunky way?
Yeah. You keep on mentioning it, so I figure you liked it. It was pretty good.
No, yeah, it was.
I didn't like the weed reference though. Do they have to call it weed? It's cannabis.
No, I know.
That's not the clinical term.
I know. Viceland is not clinical, are they?
No, they're not very clinical. But they do cover some clinical aspects, but they're a little bit more on the hip, edgy side of stuff.
Yeah,
kind of hipster world.
Anyway, so let's hear from Jessie.
Well, before the accident, it was just the nightmares were my only issue with sleeping. After the accident, it was pain and nightmares. So it was, dependent, but it was both. It was anxiety about falling asleep and, inability to fall asleep and waking up. Like I would wake up in a sweat and, cold sweat and from a nightmare.
That sounds like last night for me.
You woke up in a cold sweat?
I didn't do the sweating part, but I woke
flashes?
up. No, thank you for asking. No, but the anxiety of whether or not I was going to fall back asleep was kind of a new sensation. I think it is triggered by doing a podcast on insomnia and diving into it really deep. I know I've suffered sleeplessness before, but that anxiety gripping me was something that felt kind of fresh and new, and totally unwelcome.
And it's something that, we hear a lot. It's like this anxiety around actually going to sleep. Like, trying to go to sleep is an anxiety-inducing event.
Oh, absolutely. Absolutely. We hear that again and again. Okay, we're going to add something to the pile now. We're going to stick on the topic of anxiety, and we're going to add hormones, another obviously female-specific issue, in this case at least. And hormones are present in the body at all ages. But for women, things really start to change around perimenopause, which typically occurs in your mid to late 40s and leads into menopause, which of course is a huge life shift. And there's a lot going on, needless to say. This is Rhonda. She's a designer living here in Portland, and she's about 50.
Prior to being my age, probably in the last, I'd say 3 to 5 years, I just naturally need a lot of sleep anyway, but now I seem to need it but can't get it. As you get older as a female, your hormones start going insane and you start losing all kinds of estrogen, and estrogen is a sleepy hormone. And so as your estrogen sort of goes down and your progesterone goes down, your estrogen kind of varies, you sort of lose that sleep, and you experience a lot of anxiety. And so that's happening. So it's kind of a combination of odd times that I get anxiety. I'll just wake up a lot of times what happens is I'll wake up at 3 a.m. for no reason and just start freaking out about stuff.
Yeah, no, it's interesting because that hearing that kind of reminds me of one of the things they say that's important for sleep hygiene is to write down everything that's worrying you on a piece of paper. So you write it down.
That would take a long time. In my case.
Well, yeah, in your case. But usually there's a few things that are underlying that we're concerned about or something like that. And if we don't write it down, we'll think about it or may.
That's interesting.
Yeah.
Like a way of kind of dispelling it or?
Yeah, well, it's like, because it's almost like we have some anxiety around that we're going to forget about it or something like that, which obviously we're not going to forget about it. But once you kind of write it down, then okay, you've kind of given yourself permission to return back to it. You're not going to lose that.
To put it down for a
you're not
minute.
going to lose that thing that you're worrying about because, of course, you are going to forget what you're really worried about. But
sometimes
that's how mine works.
Sometimes I imagine that I'm writing down good ideas, but really I should just devote my time to writing down anxieties.
I think that'd be a good idea.
Yeah.
It'd definitely be probably inspiration for a screenplay or two.
I think Woody Allen.
Sleepless in Seattle.
Yeah, we mentioned that one earlier.
Yeah, I think we did.
Anyway, so okay, back to Rhonda.
Sleepless in Portland.
Yeah,
I think it's kind of a vicious cycle. And because in the morning when I wake up, I kind of go, what was I so freaked out about? Like, I don't know why I spent, 2 hours obsessing over something that really wasn't that big of a deal, So I think it's kind of hormones on overdrive, and that happens. It's kind of they call it like a hormone surge, or a power surge, they call it, in your perimenopause to menopausal time. And unfortunately, that happens kind of at night, which is why a lot of women get night sweats and that kind of stuff. So, yeah, so that happens a lot, and I think it's all kind of related, and I think a lot of times, I've tried all kinds of different things, like drinking wine to self-medicate, and of course that doesn't work because, then the red wine sugar thing wakes you up, and all that. So, I've kind of tried a lot of different things, melatonin, valerian, different herbs. And I do also get migraine headaches. And so that's been, amplified with hormones as well.
Yeah, a lot going on in there, a whole pile of stuff.
Well, I just, she mentioned Hormones on Overdrive, and actually the sequel to Hormones on Overdrive, that was actually one of my favorite films of 2015.
Thanks for that. So those are 3 kind of high-level, female-specific issues that have a huge impact on insomnia, for sure. I want to talk about some worries that float along with this, that are kind of drawn along in the slipstream, if you will. One that we mentioned earlier is talking with your physician, and I think that's a huge one that we'll go into more detail in the next segment. But talking with your family, that's one that comes up again and again. And Jessie, who we heard from just a little bit ago, hits that one dead on. So let's listen to her for just a second.
At first I wasn't going to tell anybody. I thought about not telling my kids, and then I'm thinking about them, what if they found it? Would they be scared? Probably. They wouldn't know what it was, or they, learned about it in DARE and thought I was, a criminal. So I decided that I had to tell them that was really important. And, one of the biggest things is I didn't want to teach my kids to be ashamed of my disability. Mm-hmm. So I didn't want to hide it. So once I decided to tell them, I decided that I wasn't hiding it from anybody, because I wasn't going to be like, don't tell anybody about my secret new medicine.
Yeah, that really resonates with me. I mean, I don't contend with any of the issues that she does, but that rings true to me. That's an experience that I've watched friends of mine go through as they struggle to find treatment for things that feel uncomfortable talking about. I think the talking with kids one is a huge deal, actually.
And I think, she clearly had thought about it quite a bit. And I think she took the right approach, because it's not like, what are you teaching your children if you're hiding it? I mean, this is not a recreational endeavor for her. This is like, she's dealing with multiple different issues, and it's not really any different than, she was taking worse medications before that were, prescribed. But
are we treating cannabis as medicine, or are we treating it as an illicit drug?
And it's clearly medicine.
I'm also struck by the use of the word shame. There's this idea that shame is feeling bad about something that you are, rather than guilt, which is feeling bad about something you've done.
Well,
They're
that's
very different.
Actually, and I had a conversation with, not through the interview, but a follow-up conversation with Kathy, the nurse. Uh-huh. And she had talked about canna shaming, right? So,
what is that?
Basically, the example that she had used is not Eugene Monroe, but there's another football player, NFL football player, and he had surgery. I can't remember what the surgery was, but he cannot have, for pain, the NFL is more than happy and more than willing to prescribe opioids. But when it comes to, but he cannot, and because of the surgery that he had in his stomach, it took out his intestines and everything like that, he cannot have opioids. And so he wanted to take medical cannabis. Yeah. And they absolutely won't let him, and try to kind of embarrass and humiliate him.
Oh, wow.
Because of that. And it's not like, and it was not a recreational thing for him at all. And he does not want to, why does he have to take an opioid, which we know is extremely toxic
I want to move on to one more item before we leave this segment, and that's daytime effects. Basically, will this mess me up the next day? Will I be able to function in the way that I need to around my family or at work? And Jessie, once again, hits this right on the head. Let's listen to her.
Well, I'm a nurse and I was a hospice nurse, so I just treated it the same way as I would treat any medication. And it was like I came up with this is my daytime plan, and this is my around the clock plan, and this is my PRN, my as needed. If I need it as for a breakthrough medication, in medicine, like when we treat a patient's pain, we give them around the clock medication to keep it well managed, but we also give them a breakthrough medication in case the pain does get elevated at some point. Sometimes we have to take it and bring it down. And it's the same way for me with cannabis. My low microdosing keeps me, I'm awake, I'm okay, I'm comfortable. But there are times when I need to take a higher dose or the more heavy THC, and to really relax the spasms and stop the nerve pain. And then that does affect me. Like that absolutely makes me less effective. And of course, there are all the side effects. So it's really dependent on, like, my pain kind of really controls a lot still, kind of dictates my day a lot.
Well, even again, she's talking about cannabis just like any other medicine. And I point out she is a nurse. I mean, she's applying protocols to it, which is something that not everyone gets to do, but is super important. It's super important to pay attention to what you're taking, to plan what you're taking, and have your desired goals in mind.
Right. And what's interesting, I mean, as you pointed out, Jessie is a nurse. So she is accustomed to protocols and process. But even in her situation, it definitely took, a little bit of trial and error and finessing and to figure out what exactly, how it works. And just imagine somebody that's gone through all this training and that is a professional. It's obviously going to be daunting and a challenge for somebody that doesn't have that sort of background.
Oh yeah, absolutely. Well, I mean, again, we come to this again and again. You need guidance. You can't just jump in and try stuff. That's what we hear over and over. Cool. Well, we've heard from some patients. Let's turn it around and talk to some clinicians and see what they have to say on these issues.
So we've just talked to some patients, and in this segment, we're going to talk to some clinicians and researchers about some of the scientific aspect behind everything and what some of the gender differences are and why some drugs aren't as effective or work differently with females. So let's get started with Dr. Nick.
He's a Harvard-educated PhD in neuroscience, and he's also the senior science advisor for Leafly.
It's not something I've looked in that much, but it almost certainly would have to be true. Almost certainly, just because there are going to be a lot of sex-specific differences in, receptor levels and things like that in the brain. Unfortunately, this is something that something in science that is sort of endemic. People often don't look for sex or gender differences, but they're probably widespread. That's starting to change because people are recognizing the need to do this. So there's some high-profile examples of this you can dig up where drugs that have gone to market have actually been. So when a lot of animal testing is done, historically, it's done only in male animals, and there's a couple reasons for that. One is just simplicity. You wanna reduce variation in your sample that you're testing, and the other one is variation that's related to that first one is variation due to the estrous cycle. Because hormones and things like that change in this very regular way as a female mammal, for example, is going through the estrous cycle. So people have often used that as the reason for why they used only male rodents or something in their experiments. It's to reduce that type of variability. And on the one hand, that makes sense. You want to reduce that variability to have better control over conditions. On the other hand, we know that there can be huge sex-specific differences in the way that different drugs or substances affect the nervous system. And you can dig up a couple of examples of drugs that have gone to market that have been largely tested in mostly male populations. And then later on, after they've gone to market, we learn that they have some different side effect or something in males versus females. But at this point, it's too late because people have been prescribed the medication and have seen some problems.
It's really interesting, actually,
I was going to say that kind of stuns me.
Yeah, I mean, I had no idea, but it makes a lot of sense because if you know sort of the history of a lot of different drugs, it's not until after they hit the market or they've been used for a while that we learn that they have some really adverse reactions or adverse effects in people.
And and adverse effects on females.
I mean, specifically on females, exactly.
Those are the people they're not being tested on.
Right.
Wow. So there are absolutely differences, for sure. I think one of the points that Nick raises is that if these drugs aren't being fully tested on women, it's hard to predict their interactions with other drugs. Those drug-to-drug combinations that we've referenced before, they nullify each other, they amplify each other, or they just react in kind of unpredictable ways. That's actually kind of a huge issue, and it's one that affects cannabis as well.
And cannabis is more benign in terms of interactions with other drugs than quite a few other prescriptions and stuff like that, but there are still issues, and Eloise touches on that.
Right. Eloise Thyssen is a nurse practicing in California, and she hits a nail on the head. Sorry, I've used that
I think
metaphor.
You can only use that once per episode. Okay. I'm sorry.
Okay, here's Eloise.
Yeah, and my other thing is there's usually there's potential for drug-to-drug interactions, and often what I see is that cannabis will increase the effectiveness of their other medications, and those medications need to be either reduced or eventually eliminated. And if I didn't prescribe those medications, I feel like it's it's a professional boundary issue for me to come in and start taking over that section of their care. We need more collaboration among medical professionals, and it's not there. We're not there yet.
Yeah, she touches on several issues there.
Well, and I think Eloise made a point that is really important to highlight, and what I touched on earlier is about drug interactions, but that cannabis generally is doesn't adversely react with a lot of drugs, but it's not uncommon for cannabis to potentiate other drugs. So in those situations, it's important to reduce the dosage, or ultimately, as some other patients have reported, eliminate them altogether.
Right, to just get off those drugs. Mm-hmm. And cannabis, in some cases, makes it possible. I mean, in episode 4, we're gonna meet a senior who got off an insane cocktail of meds and is largely now just on cannabis and really regained her life in a pretty dramatic way.
Well, that's been actually the case with a number of the guests.
Yeah, that's actually true.
Yeah,
that's totally true. I want to turn back to the issue of shame. This may be a Freudian direction on my part, but something that Eloise talks about as well, and we'll hear that in just a minute, goes back to talking to your physician, which is really one of the core issues that patients come to us with. Patients feel a lot of shame, and physicians can exacerbate that shame around cannabis specifically. And it's a real inhibitor in having a true dialogue about your health, which is obviously what this is about.
I try to encourage them. They'll usually ask me, should I tell my physician? And I always say yes. I think transparency is important. And I let them know that I think that they'll most likely be educating their physician. That it's important that we have this dialogue because more often than not, they're getting the relief they've been seeking when they weren't before. So, letting these practitioners know that it's working. And it's hard for them. It's really hard for them to be brave because they're afraid of being judged. They're ashamed that they've come to cannabis. A lot of my patients come in and see me and they're not happy they're there. Right. They're like, look, everything else has failed and I'm just disgusted that I'm even in your office right now considering this drug. And I'm like, okay, great. Trying to get them to have the courage to have that conversation, it takes some coaching and, really a lot of, encouragement. And when they do, it's usually positive. Their biggest fear is the physician's no longer going to treat them if they find out that they're using cannabis. And I haven't found that to be true.
Well, that's good to hear because I know some other people have different stories that MDs don't want to treat them. Or they certainly don't want to talk about cannabis at all. That leads us to our next clinician guest, Dr. Jordan Tischler. He's a Harvard-trained holistic care expert, a doctor, of course, and a leading expert on cannabis therapeutics. He's an eloquent interviewee, and he talks about the need for honesty in a way that I really appreciated. Let's hear him.
The short of it is that your physician is there to help you. And hopefully their only goal in life with regard to you is to help you be the best you can be. So I think that it is important for a patient to be honest with their physician. And I also think it's important for their physician to be non-judgmental with the patient, which is not to ever say, no, I don't think this is a good idea, but you better well have reasons and back it up that are better than Harry Anslinger said this isn't good for you.
Harry Anslinger, my favorite guy.
You've been waiting weeks for this moment, haven't you?
So who Harry Anslinger
be free.
Harry Anslinger is actually the number one person why we actually why cannabis went out of mainstream medicine.
Yeah.
Essentially.
Yeah, he was, a prohibitionist in every sense, right? Was he elected or appointed? He was probably appointed.
No, he was appointed. He was the first official drug czar.
He was the drug czar.
Yeah. But it was the Marijuana Tax Act of 1937 that really kicked things off.
It was a wonderful act. Okay, let's get back to Dr. Tischler.
One of the other thing back on the topic of communication that I really try to impress upon patients is that, I ask all the patients to send me their medical records before we get to sitting down. In fact, it's a condition before I'm willing to accept them into the practice. And, this helps me understand what's going on with the patient, and it helps me provide appropriate care for them. And it also helps me keep the practice truly medical.
Yeah, we couldn't agree more. It's funny. Did it occur to you to interview an MD who is anti-cannabis, just to have a really confrontational interview with him or her?
That's a good question.
I offer it jokingly, but it's serious as well.
Yeah. I don't really know that many that are anti-cannabis in sort of a general sense, but are more...
Are they condition specific?
Either they don't know enough about it, or they have certain concerns, which are absolutely legitimate, because that's why we created Zana in the first place. And that is because there's lack of controls in terms of...
There's no protocol.
They don't have the protocols. And so when am I prescribing this patient? And so I totally share those, I share those concerns, obviously.
Yeah. Yeah. No, that makes sense. All right. We want to wrap up with something Eloise said that just seems so spot on about managing expectations. Let's hear that first.
I would say that, I think it's important to manage expectations. I think a lot of what is sort of put out there, gives this misconception that it's a silver bullet, that it's going to, work quickly. And I think there's a lack of information around, the actual process, that you should really be working with somebody who is knowledgeable in cannabis as a medicine, and also understands other health conditions, your particular health condition and your medications, and that, that working with somebody will improve your success, will improve your outcome.
Yeah. Again, we couldn't agree more. The need for guidance, the need for personalization, and for methodology. Okay. Finally, this is the real wrap up. I just loved these two quotes from Paige and from Rhonda, respectively. So I wanted to end this episode on those two.
Actually, the stuff I learned from the CBT was really useful. And if I'd learned that earlier, it would have helped.
So CBT is cognitive behavioral therapy. And they actually have special cognitive behavioral therapy. CBT is used for a lot of different things, but it's also, they have a format or form modality. It's CBTI, which is specifically for insomnia. And it's basically practicing different techniques without drugs or anything like that help you find ways to fall asleep.
And that's something that can be accessed through a good book.
You don't even need to go pay for the treatment. The kind of sleep hygiene tips that come in there are really helpful and beneficial. And the more I've adhered to them, the better the quality of my sleep has been. So yeah, I wish maybe I'd learned that earlier, because I can look back at like when this first started and I was kind of doing everything wrong, and I don't think that would have stopped it from arising, but there's something too about knowing you're doing the right stuff, and that also makes it a little more out of your control. I'm like, okay, well, I did everything I was supposed to. I still have it, so whatever,
Right. So bringing to that,
not any self-judgment there,
and the acceptance.
And I know when I break those things. So, for example, if I'm going to smoke and go dance, I'm probably not going to sleep well that night, and then so I have to know that I'm giving that up. And then it's kind of a conscious choice, like, okay, I'm choosing to do that.
Yeah. That's so powerful about taking agency over a condition that can feel like it's taking control over you.
Well, the other thing, though, I thought about when she said, so she's created this association between going out and dancing,
right,
and cannabis, right? So there's her brain has sort of learned to associate these two things, right? So it's not totally surprising that it's hard for her to. I don't know if there would be some. I mean, she'd have to retrain.
Exactly.
To take some retraining in terms of her brain to lose that association.
Yeah, that's a really good point. Okay, let's finish up with Rhonda.
It is different for everybody, and especially with women who are in perimenopause or menopause. Everybody's experience is different. And so one person who says, oh, I tried, wild yam root and it cured me, it might not cure you. It might not even work at all for you. So it's like, what works for you? If cannabis works for you, but you don't like the THC, go for something high CBD. If this other thing works for you, but it didn't work for your friend Claire, then don't try it. It's like you just have to keep working with stuff until something hits right with you. And don't be afraid to talk to your doctors. If your doctors try to brush you off, don't let them. Because it's not all in your head. It's absolutely in your body, and you know what's best for you.
I was going to say she hit the nail on the head, but that would be wrong, of course.
You cannot say that anymore.
I know.
You're banned.
Yeah. But I think what she said just really resonated with me so deeply. I mean, again, the fact that everyone is different, and you have to trust your own judgment at the end of the day. And you also need to seek real authoritative guidance, a source that you can trust to help you, because this is complicated stuff. There's a lot of trial and error, and it really helps having someone taking the error out of that process.
Taking the air out of that process?
Error.
Oh, error. I was like, air. The oxygen out of the process?
No.
It sounds deflating.
Yeah, literally. All right. Let's leave it at that. Thanks, Jeremy.
Thank you, Seth.